Good afternoon, everybody. Unfortunately, a live scan will not be possible, so I will replace my live scan with a talk about the normal fetal heart as seen on echocardiography. I will focus on the standard views used in screening, the laterality view, and tell you something about color and pulse wave Doppler. First of all, I'd like to alert you to the ISUA guideline for fetal echocardiography. Most of what I will be talking to you about in this talk falls in the best practice section of the guidelines. When starting to perform an echocardiogram, the first thing that one should do is determine the lie of the fetus. Is it cephalic or breech, or possibly lying horizontally across the maternal abdomen? Be sure that you know what is the fetus's right and what is the fetus's left side. Then make an axial cut through the abdomen. Check that the stomach is on the left side along with the aorta. Check that the vena cava inferior is visible to the right and anterior from the aorta, and that you can see the intrahepatic part of the umbilical vein. The normal arrangement of organs in the body is called situs solitus. In this situation, the right atrium receives the vena cava inferior and the vena cava superior, and the pacemaker is found in the right atrium. The left atrium receives the pulmonary veins. The stomach and the spleen are found on the left side of the abdomen and the liver on the right. The right-sided lung has 3 lobes and the left-sided lung has 2. And there is a more vertical arrangement of the airways on the right side compared to the left side. So let's have a look at this example. Here the baby is breech with the back to the mother's back. What do we see? We see a stomach on this side, and that is the right side. We see an aorta on the left side, and anterior and to the left we see a vena cava inferior, and we can identify the hepatic vein. So here we have right-sided isomerism. How can we be sure that this is right-sided isomerism? The usual arrangement has the aorta on the left with the vena cava on the right side of the spine. Mirror image is when that situation is inverted. If we have a vena cava inferior to the left and in front of the aorta, we have right-sided isomerism. And if we do not identify a vena cava inferior, but we see a dilated azygous vein behind the aorta, that is suggestive of left atrial isomerism. Let's look at the 4-chamber view and let's have a look at all the things we can see in it. Now, this was introduced as a screening view in 1985. And initially there was lots of excitement because in expert hands it has a sensitivity of 80 to 90% for the detection of heart defects. But in general, usage in low risk populations, it was disappointing with only a detection rate between 30 and 50%. What do we see? We can see on the left side the left atrium with the pulmonary veins coming into it. We see the mitral valve. We can see that the left atrium is connected to the left ventricle. We can also see that the right atrium is connected to the right ventricle, and we can see the foramen of our left flap bulging towards the left side. Once we've identified what is the left and the right side of the fetus, we should be able to see that the apex of the heart points towards the left side. We should be able to see that the axis of the heart with regards to a line drawn through the middle of the fetus through the spine, that angle is about 45 degrees. Should this angle be increased and with a more sort of horizontal position towards the left of the heart, this has a high indication for congenital heart diseases, particularly conotruncal lesions. I've already told you many of the things we can see on the 4-chamber view, but it's important to see that we have opening and closing valves. We should look at the offsetting of the valves. The tricuspid valve insertion is deeper in the ventricle, And we should be able to see that the right ventricle is indeed a right ventricle and the left ventricle is indeed a left ventricle. A right ventricle is slightly more trabeculated. It has a moderator band, and the tricuspid valve inserts on the side of the septum, whereas the mitral valve has a connection to the papillary muscles and does not have a connection to the interventricular septum. So let's have a look at the insertion of the tricuspid valve on the left. In a normal case, you see there is a small offsetting, not very big, and in a patient with Epstein's anomaly, that distance is increased. Here we have an example of two cardiac defects detectable on the four-chamber view. On the left, an atrioventricular septal defect with a defect in the center of the heart giving a VSD, an ASD primen, and a single AV valve. On the right, we have a hyperplastic left ventricle, and it's very easy to see here that this left ventricle is far too small to function independently. So here we have a quiz for you. Is this normal or abnormal? And is this one on the right normal or abnormal? So let's put the labels in. Here we can see that there is offsetting between the valves here, such that the tricuspid valve is located on the left side. And we have an anatomical right ventricle where there should be a left ventricle. And the anterior ventricle here is a left ventricle. So this is the case of corrected transposition of the great arteries. If we have a look at the image on the right, we see that the aorta is located on the left side, and this heart is actually pointing towards the right. So this is a case of dextrocardia. If we scan upwards from the four-chamber view in the direction of the fetus's left shoulder, the first cut that we come to is the left ventricular outflow tract. We can recognize the interventricular septum having a continuity with the posterior wall of the aorta. We can see the aortic valve opening and closing. We see the mitral valve opening and closing, and we see a continuity between the mitral valve and the aortic valve leaflets. The usage of the four-chamber view and the outflow tract views in expert hands has been recorded to have a sensitivity for the detection of cardiac defects between 75 and 90%. When used in the screening setting, however, the sensitivity is only around 60% if only these two views are used. Scanning further up, we come to the right ventricular outflow tract view, which is depicted in the video on the right. I have also shown on the left the short axis view showing the right ventricular outflow tract to pulmonary artery, and the sagittal cut showing the right ventricle to the arterial duct. One should be able to see the pulmonary valve, one should be able to see the both pulmonary arteries, and the connection of the pulmonary artery with the arterial duct. In these two cases, abnormal left ventricular outflow tract are shown. If we look at the video on the left side, we can see that there is a loss of continuity between the interventricular septum and the posterior wall of the aorta. So in this case, we have a malalignment ventricular septal defect. On the right, you will see that the left ventricle continues into a vessel that splits into two. That is a pulmonary artery. So in this case, we have transposition of the great arteries. As we scan a little bit higher, we come to the three-vessel and trachea views. On the three-vessel and trachea view, which is depicted in the video on the left side, we can see the pulmonary artery, the aorta, and the vena cava superior in a nice line, with the size decreasing from pulmonary artery to vena cava superior. On the right side, we see a normal three-vessel and trachea view, where we see the pulmonary artery connecting to the arterial duct, which then connects to the aortic arch, making a V shape on the left side of the trachea. It can be difficult, but it is important to also view your aortic arch and your arterial duct in the sagittal plane. You will see here that the normal aortic arch has a more curved shape, like the umbrella handle or the staff of Saint Nicholas. The sagittal view of the ductal arch shows that it has a more hockey stick-like shape and does not have the curved, rounded umbrella handle appearance that we see in an aortic arch. It is important to evaluate your pulmonary veins, and I showed you that very briefly in the beginning on the 4-chamber view. And it's important to identify at least one pulmonary vein from each side. And just as you must identify pulmonary venous return, your systemic venous return is also important. And here we see the bull's sign, sagittal cut, that shows us the vena cava inferior draining into the right atrium and the vena cava superior draining into the right atrium. And that is a passage of desaturated blood. Oxygenated blood comes through the umbilical vein, through the ductus venosus, and crosses across the foramina file, entering the left atrium, which we can also see in this video. The use of color Doppler is an important addition to 2D echocardiography. When the machine is set correctly, you should only have turbulence in a normal heart across the venous duct. On the 4-chamber view, we should see laminar flow across both AV valves, filling with a jet that is comparable between the two sides. We should see laminar flow across the outflow tracts. We should see the outflow tracts crossing. And when we look at the 3-vessel and trachea view, we should see flow in the ductal arch and the aortic arch in the same direction. Color Doppler can be especially helpful when looking for ventricle septal defects in the fetus. It is important to appreciate the anatomy of the interventricular septum. The yellow areas that are demarcated here all form part of the interventricular septum. However, the dotted line shows us the cut that we get when we look at the 4-chamber view. So in fact, we're only looking at a very small area of the interventricular septum, and we will miss all the other VSDs if we only use that cut to interrogate for ventricle septum defects. That is why I like to make a sweep from the 4-chamber view up to the 3-vessel and trachea view, so that I have had a look at all areas of the interventricular septum. Now, when you make a stick 4D volume, in fact, your machine is doing it for you. So make a volume and watch. I found that a very good way to get an idea of the entire heart in a sweep, which can be with color or in black and white, of the entire fetal heart in a very short period. In this example, we see the benefit of color Doppler. This is a rather late 3rd trimester echo where we actually don't see any VSD. But if we look at the color image on the right side, you see there are two small apical ventricle septum defects seen on color Doppler. When diagnosing a VSD on color Doppler, it's important to see that there's flow in both directions. In systole, we see left to right shunting, as in A. In B, we see end systole with a flow change to a right to left shunting. In C, we see diastolic right to left shunting, and in E, end diastolic flow change to left to right once again. Here we have an example of a ventricular septal defect where we see flow predominantly from left to right. This should make us aware that there may be either obstruction proximal or distal to the ventricle. In this case, where we have left to right shunting across the ventricular septal defect, we should consider the possibility of obstruction of the aortic valve or a coarctation, and we need to interrogate that part of the heart very carefully. I already showed you on the pictures of Dr. Carvalho that in a normal heart, in the three vessel and trachea view, you should have color flow in the same direction in the ductal and aortic arch. And that we can see on the example on the left side. On the right side, we see that the flow in the aortic arch is in another direction to the flow in the arterial duct. If you see this, congratulations. You've just diagnosed your first ductally dependent lesion and potentially saved a baby's life. Color Doppler examination is particularly useful when examining a very young fetus. It is difficult on the black and white images to identify all the features of the cardiac anatomy. However, with color Doppler, we can see equal filling of both ventricles, and we can see the outflow tract of the right and left ventricles coming together, making a V as they should. Pulse Doppler interrogation of the valve of the heart is important. When looking at the AV valves, we should be able to recognize two waves, an E and an A wave. The E wave represents passive ventricular relaxation, and that is the passive filling of the ventricle. The A wave represents active atrial contraction, so this is active filling of the ventricle. When measuring flows across valves, it's important to have your angle correction less than 30 degrees. Otherwise, you cannot measure the peak velocities. Your setting of your machine is, of course, also extremely important. When looking at the AV valves, we should not only be looking at the flow across the valves, but we should also exclude any regurgitation. On the right below, we see an example of tricuspid regurgitation. You see highlighted in yellow the regurgitation. This is important as in early gestation, the presence of tricuspid regurgitation can be a marker for chromosomal abnormalities as well as cardiac abnormalities. The flow across the semilunar valves gives us an idea of the ventricular output. The time to peak ejection across the pulmonary valve is shorter than that across the aortic valve, and that is a reflection of the afterload of the ventricles. At 20 weeks gestation, the peak velocity across the semilunar valves is usually about 60 centimeters per second and certainly less than 100. But when one is looking at a very small fetus, it is important to set our settings for the aliasing of the color flow with a velocity greater than 40 centimeters per second across the aortic valve. In this case, at 12 weeks, a pulse Doppler velocity of 72 centimeters per second was recorded. And at 20 weeks, this baby had already developed critical aortic stenosis, which could easily have been missed if the only color Doppler was used and the settings were not correct. We come then to the normal venous Dopplers. Here we have a normal ductus venosus with the S, D, V, and A wave. The A wave should be positive. Here we have a normal vena cava inferior Doppler where a small negative A wave is normal. And the umbilical vein should not be pulsatile after the first trimester. The presence of pulsatility in the umbilical vein is an ominous sign. One should always look at the flow on Doppler in the ductus venosus, especially in the early pregnancy, because an abnormal ductus venosus flow can be associated with an increased risk of congenital heart disease. On the right top, we see a normal ductus venosus flow with a positive A wave, and below it we see an abnormal one with a reverse A wave. So what are my take-home messages? Practice. The more you do, the better you get. Be systematic and look carefully. Think about the hemodynamics of the heart when you echo it. Color is essential for first trimester scans. When scanning in the first trimester, limit the time of pulse wave Doppler using the Laris principle. The laterality view, I suspect, will become more important in screening protocols. And don't forget to check for extracardiac anomalies. Thank you very much for your attention.